Oh, this has been going on.
It was scratchy.
I don't know. They really don't like it.
Had her adjust, her microphone, but it wasn't. This is the first time we're not that way. Like all the time. I get it all the time. I'm like, oh, so they're very complicated.
Those are my friends. I said the more I learn, the less thing I understand.
Yeah.
Spiraling out.
They're using it's just out there.
Where's the bargain?
Sorry. Kids that are
Yeah, I mean, if Joe was the one who sets it up.
I think they were allergic anyway.
Joe, you know last week there was an audio problem.
The funny part is, setting this up all
They're like, I'm coming down, I love it.
I love like 3 hours, 2 hours into it.
That's awesome.
I was like, well,
Who knows if you can stop the curse? I mean, you can handle it. Really?
Up to that point, it's called they're going to explode. As far as I can tell, it is like have you seen that yet? Like it was 4 months old. It had its undeveloped like high as a swallow.
I don't know about that. I haven't read it before.
I mean, Chuck saw it in like 29.
What do you find when they come out of
I just did it the first time. So we woke up like 3 days before I saw him. Dad had this concoction of look that we were just dad. The dad's like a paramedic or something. He's swirling all over his children by children it's super remarkably and then still the same neighborhood as
You get a senior.
There's something before about Medicare, right? It knows no bounds. You get it right at like
I know. Exactly.
Everything else can smell the I'll get some yeah, and your peanut allergy.
I'm like, who?
That are all the same level. It's crazy what I do. That's your
Throw that out there.
I know what it is.
All of them. 7 billion. They condition almost every one of them. And the primary symptom. I got that case of my
So the question, are you
I grew up.
what?
what I'm doing. What are they going to do when we're all retired?
You're right. There's probably some truth that one. Your son, my son.
Hey, did you look at the minutes?
Right.
Okay, do you have any corrections? Obviously not.
Oh, that's incredible. So you can never. That's right, that's going together. Oh, yeah.
Oh, you're just, yeah.
Doing it.
I do it for an hour long.
Let's say.
We've been doing it from the nursing home. No, that's cool.
In Paris.
Actually, I have some good people set up already.
21st birthday.
Just call them on the phone and call them guys.
We gotta get some.
A lot of it.
Snake's the last one.
It's an important topic. We got only one fellow here.
I can leave.
They're gonna have to repeat the year if they don't show up.
Great food this morning. Thank you.
Thank you.
Whoever you found the berry.
I presume some people will be here shortly.
Maybe it's because they've heard this talk before.
Maybe I'm the only one who forgot it.
No, I did change something. Amy, how many are online? You can't tell.
With this new system, we used to know.
100.
Raise your hands early morning.
That's right.
No, we can't tell who's watching, but they have to put in their word of the day. So.
Well, I assume some more people show up. The only comment, so MCAD is the word of the day for CME. And so this is the last Tuesday morning session of the year. And for those, especially on the outside listening, the last session is dinner over at, what is the name of that place? Ayars? Ayars. We'll start at 6:30, and it's Thursday of next week, not Tuesday, Thursday of next week, kindly sponsored by Jerry and Genentech. And how many years we've been doing that, Jerry?
Oh, I'm going to guess close to 8 or 9 now.
Yeah. Well, thank you very much. So, Drew, again, is going to review mast cell disorders for us.
Thanks, Len. So before I forget, I went through this last year, but if you go to the Allergy and Immunology UW Fellowship page, there's a link here down at the bottom left for the A&I teaching series. You can go through and review previous talks, and it's actually pretty nice. You can get it on your smartphone and listen with your headphones. Here's mine from last year, and it runs through the YouTube format. And as you can see, I have 32 views here from last year. 29 of those are from myself. But no, it is a nice system, and it's very easy. We can't keep all the old talks on the server we have it on because there's limited memory. So as quick as they can, they put it up on that website. So hasn't gone viral yet, but I'm keeping my fingers crossed.
Do you know if anybody else, any other divisions have a similar service?
I don't think so. No, not that I know of. But no, it's very nice, and you can go back to 2009, so let's go way back. So, evidently Len forgot everything I said last time, and I know my dad was sleeping through the talk, so he'll get something out of this. No disclosures, and just to go back, this past week, King 5 and Cairo interviewed Dave and Bill, and they had a really nice showing and were great at putting the word out about food allergies, CFAC, and the VIPE study. But this is from The Onion, they call themselves America's Finest News. And they have some theories about this as far as what restaurants are serving. The crispy histamine sandwich evidently can cause anaphylaxis. The anaphylactic Kraft mac and cheese is one of the big offenders. Last night's lo mein, hard to say. And then evidently they're serving cat hair, so there may be other reasons for this. So, the overview, similar to last year, and again, I find this stuff fascinating. It's maybe the 4th time I've gone over this, but again, my dad was sleeping for the first 3 or 4 of them, so there's a new article out that I actually just found this weekend that I find fascinating as well, just outlining the role of mast cells, and specifically their role in helping lower mammals fight off envenomation by a lot of different things, including bees, Gila monsters, and things like that. I love this table, and I'm going to go through it 4 or 5 times throughout the talk. This is what I refer to not only for myself, but I go through this with patients when I'm telling them how I'm working them up. Looking at primary, secondary, idiopathic mast cell disorders. You have mast cell activation syndrome, or mast cell activation disease, which is the primary disease, which consists of mastocytosis and monoclonal mast cell activation syndrome. This year I've tried to incorporate some history as to when these diseases were known and when we started screening. And then there's a great paper that I've reviewed 3 or 4 times as far as who to screen, and it's something I have to review several times per year. Then there's mast cell activation syndrome, which we'll try to get into at least a little bit. And then mast cell disease and Hymenoptera anaphylaxis. So during the meeting, I went to all the mast cell talks, and one of the major themes is there may be a different phenotype in males who only have anaphylaxis to Hymenoptera and severe anaphylaxis with syncope. So I'll review some of that data. Same case I went over last year. 50-year-old male seen in the community had facial flushing, pruritus, hand swelling after this Bolthouse chai tea drink, which again I've seen 2 or 3 people react to this drink. Later vomited, called 911, and he was fairly hypotensive during that episode. Tryptase level was 39 at that point. Second case, these are more of what you see in clinic. The 42-year-old female, periodic hives, mild angioedema associated with it, lightheadedness, and no clear trigger, despite the thorough workup that we always do for these people in clinic. This seems to go along with all these patients as well. Geez, I just can't concentrate as much as I used to. Work, the things I used to do at work are a lot harder. You get a baseline tryptase that's normal. During an episode, it's 9. Started on cetirizine, and she believes the number of episodes have decreased. So what label do we give this patient? And finally, 40-year-old presents for evaluation after bee sting. Had a nice history, diffuse wheezing, hives, lightheadedness, was given epinephrine. Question is, should we screen for mast cell disorders? And when I say that, get a tryptase level. That's all I would do in someone like this. And upon further workup, the RAST and skin prick and IDs are negative. So, does this make it more or less likely that that's a mast cell mediated disease? So, from an evolutionary standpoint, why the heck do we have mast cells? And I find this data very nice. So this group from Gale, who does a lot of nice work, and one of his disciples, Adrian Piliponsky, here is at Seattle Children's, who's great as well and putting out a lot of research on his own. The first paper looked at mast cell knockout mice, which they have a nice model for that, and looked at envenomation with the mole viper venom, which is a snake mainly located in the Middle East. They have a bunch of different toxins, including seraphotoxins, endothelin-1, and which is a potent vasoconstrictor. They promote degranulation of the endothelin-1. And it's been shown in very nice experiments that having mast cells is a good thing when it comes to envenomation by these things. Here you have the temperature change, and they use that as a marker of anaphylaxis. Here's the time after envenomation. Here's the kit knockout mice, and you can see their temperature drops precipitously. Here's the normal mice, and here are the mice, the C-kit knockout mice, where they actually add back mast cells, and they do similar to the wild type. So mast cells seem to play a huge role, and you'd hate to be one of these mast cell knockout mice because none of the 9 survived, whereas all of the wild type, the 5 out of 5, and all of the knockout mice where they added back mast cells survived. So it seems fairly clear that mast cells offer assistance in this. This is another paper I loved. And, I saw a talk on this, and he loved it because he got the Gila monster out, and this was done in October, so a nice Halloween theme. So the major toxin in Gila monster venom is helodermin. It's similar to VIP. It promotes secretion of H2O and electrolytes, and increases gut motility, and they dilate blood vessels. So it's similar to the VIPomas that I don't think I've ever seen, but it's a similar clinical presentation. And mast cells degranulate in response to VIP. And again, the authors found similar findings. The change in body temperature on this axis, and the time after envenomation. As you can see, the wild type do very well. The mast cell knockout mice that have been given mast cells do very well, but the mast cell knockout mice do very poorly during these experiments. He tested a lot of other things and found the exact same results. The western diamondback rattlesnake, southern copperhead, honeybee, which I find interesting as well. And there's another paper that they put out in the last year that I'm going to review, going over this as well, that shows not only the role of the mast cell, but also the role of specific IgE. It may not just be there to cause anaphylaxis. And this is that paper. I just found this a couple days ago, so I didn't have a chance to do it justice in our paper. So donor mice were either injected with honeybee venom or PBS, and that was done right here at the beginning of the experiment. They had a challenge procedure 3 weeks later, and actually, it's a very elegant experiment. They collected the sera from these mice, either from the bee venom injected mice, and it was pooled. And they treated it several different ways. They did nothing to some of the serum. They heated part of the serum, and their rationale was that makes IgE less potent. And they also use anti-mouse IgE as well. And then they transfuse them into age-matched recipient mice. And it shows a challenge with the bee venom serum, i.e. they didn't do any heating, they didn't use any anti-E's, they gave them the serum of the mice that had been inoculated 3 weeks earlier, who had IgE to this bee venom. It's kind of small here, but you can see the survival is much better. So the mice with IgE seem to have a significantly improved survival compared to the ones that just got PBS and who weren't immunized against this venom, or those that were heated or had anti-IgE serum. So this IgE seems to play a role beyond anaphylaxis, obviously. That's what we worry about, but it seems to be protective, especially in the smaller mammals where getting stung by these or bits are much more serious. They might have much more serious manifestations. And I really encourage you to read this. It's a fascinating read. They did the same experiments in this paper with mast cell knockout mice, similar to what's been shown before. They did it in mice where the high affinity IgE receptor had been knocked out, and they had similar results there. And they did it in IgE deficient mice. And again, the IgE seems to play a major role in defending these mice against envenomation by honeybee. And they also did a similar study with viper venom. So we think that IgE plays a major role in protecting the lower mammals against these venoms, and they hypothesized that because the mast cells sit right by these blood vessels and in the skin, that's a obvious portal of entry. Matt?
Did they look at, or did they test, is the idea that once they're sensitized and have IgE, they can tolerate a higher dose of venom, or?
Yes.
Yeah, that's how they.
So they use low dose and then high dose venom, and especially the low dose, the mice did much better. The high dose, they did have some fatalities, even in the ones that had been immunized, basically. But yeah, they looked at different doses of venom. So the mice, it seems to confer a survival benefit if you do have the specific IgE against these. So. And they, who knows whether this is true, but they went into this experiment not knowing what they were going to find, whether the mice would have more in the way of anaphylaxis, and they're, the ones that had been immunized would have even a lower chance of survival. But yeah, no, it's a fascinating paper. It's a very quick read. I recommend if you guys have time. It's fascinating.
Drew, two questions. One is the knockout. If you don't give them a venom, the lifespan of these animals normal if they're just have
for the mast cell knockout mice.
Mast cell knockout.
Yeah, they have a normal lifespan.
Without a challenge.
Yeah.
And the other thing is, I thought I remembered that IgE is not the anaphylactic antibody in these animals. That it's a subclass of IgG in mice.
Actually, they looked at IgG as well, and both of them were elevated. But in these it seems to at least play a role because, they just did the IgE knockout mice, and they had similar poor outcomes.
But I don't think they get anaphylaxis via the IgE mechanism as humans do. Or am I wrong?
I didn't mention that in the paper. I'd be lying if I said I knew that. But at least in mice, and at least in lower mammals, IgE seems to be something that's essential to them. So I don't know about us and whether it causes anaphylaxis at different rates in humans versus mice. That's a good question, and they didn't address that in the paper. So mast cells aren't just there to put our kids through college, pay for my dad's wine, but they seem to play at least an evolutionary role in the lower mammals. And I think this is fascinating stuff. So mast cells, and I'm going to briefly go through this. You guys all know this. They have a bunch of different mediators that they secrete. The main ones are histamine. Tryptase, obviously, is what they secrete and is more specific to the mast cell. That's why we usually measure the tryptase when we're looking for mast cell-mediated disease or degranulation. And then they have a bunch of different surface receptors. So these are very complex cells. I'll give you a few seconds to memorize this. This is basically to show the same point, that these are very complex cells that have a lot of different interactions. And getting back to this categorization, the reason that they propose that there's so many different clinical presentations of mast cell disease is all these different mediators that they produce. But again, the main ones are the histamine, and that causes a lot of the symptoms that we see in clinic. Again, I love this classification. I use it all the time. I print it off. I go through it with patients, just showing my thought process of going through mast cell disease. So primary mast cell disorders, we'll go through mastocytosis, and then this monoclonal mast cell activation syndrome, which first started getting some press back in 2007, and I'll review that. I think this group is very savvy looking into these secondary causes, and I won't go through that too much in this talk, but allergic disease, IgE-mediated mast cell-associated chronic inflammatory or neoplastic disorders, I'll go through that briefly on another slide. Physical urticarias, autoimmune urticaria, obviously, I don't need to talk to you guys about that. And then this idiopathic category, which is the trickiest, obviously. And then mast cell activation syndrome, and trying to differentiate these folks from these folks. There's a nice paper that I've reviewed before and I'm going to review again today. Just saying, because obviously to diagnose this you need a bone marrow biopsy. And we obviously can't send everyone we see with these type symptoms for bone marrow biopsy. So there's some nice criteria that I use and the group in Spain uses to help kind of differentiate who should get a bone marrow biopsy and who shouldn't. So as far as mastocytosis and urticaria pigmentosa, this goes way back. This has been known for a long, long time, and this report in 1883 was not the first report, it's just the first one in PubMed. So this goes way back. The second paper was in 1908. It was very interestingly written. A patient was a married lady, aged 40, who for 8 years had slowly increasing eruption of macules on the forearms. They demonstrated the presence of mast cells in abnormal numbers in the papillary body of the corneum and around the surface vessels. So they were able to pick out these patients prior to all this. And in 1908, Dad, weren't you a co-author on that one?
They're older people than me. Don't pick on me.
I saw Len's name there too. And Nick. So, mastocytosis, again, you guys know, although that it depends on where the mast cells are, so it can cause respiratory symptoms of bronchoconstriction, cardiovascular symptoms, reduced blood pressure, hypotension is what we worry about, skin symptoms, these are all stuff GI, abdominal pain, nausea, vomiting. You can also get symptoms from mast cell-mediated infiltration of different areas. In the skin, there's kind of overlap there. You definitely see the nest of mast cells in the skin, and that's what I screen every patient that comes in for a new mast cell evaluation for. If you get infiltration in the bone marrow, get anemia, thrombocytopenia, we do have one patient that has some of these features, and I at least try to do an abdominal exam looking for hypersplenism and hepatomegaly in these patients as well. So what drives this? What drives mastocytosis? So stem cell factor is the major cytokine involved in mast cell growth and mast cell differentiation. Most young progenitor cells have or require stem cell factor to develop, but most of the cells lose that the need for stem cell factor, whereas the mast cells require it throughout their growth development and for their survival once they have developed. Not only increases the numbers, but it enhances mast cell-mediated IgE degranulation. So the KIT receptor here is on mast cells, and it's a transmembrane receptor for stem cell factor encoded by c-KIT, which is on chromosome 4. It's a member of the tyrosine kinase family of growth receptors. And again, it's expressed on a variety of hematopoietic stem cells, but most of them lose their stem cell factor receptors. So mast cells are the one cells that constantly require stem cell factor. And once mature, again, they require this for survival, which is key. It also is involved in homing mast cells to the sites of inflammation. So here's a c-KIT receptor. Here's the N-terminal end, which is the receptor, and then the transmembrane portion, and the terminal, or the C-terminal there. So you get your stem cell factor, goes into the KIT receptor, and signals by phosphorylation through a bunch of different signaling pathways, which end up in mast cell growth, differentiation, and survival. So, where the problems in people with mast cells, and most of these are somatic mutations, meaning they weren't born with them. Most of them are down here in the catalytic domain here. And the most common of those is the D816V mutation. And unfortunately, this mutation causes autophosphorylation, which basically takes the rest of the receptor out of the equation. So no matter how much stem cell factor you have, usually the problem is down here. And you can also cause signaling that can potentiate antigen-mediated degranulation. So not only are there increased numbers of these cells, but they're also more tricky, if you will. And unfortunately, we have a great treatment for the KIT receptor, but Gleevec up here blocks upstream. So unfortunately, Gleevec is not a good treatment for any patient with the D816V mutation, which unfortunately is about 90% of what these patients come in with. So to diagnose systemic mastocytosis, you need one major criteria, and that's multifocal dense infiltrates of mast cells. This has been known for many, many years. And then the minor criteria are more recent, looking for spindle-shaped mast cells, and they're very easy to pick out. There's a lot of good pictures online. I should have included one, but you look for the c-KIT point mutation there. And then you also look for abnormal markers on these cells, meaning they're aberrant cells and not typical for normal mast cells. And the two major ones are CD25, which is involved in the IL-2 receptor, and then CD2, which is an adhesion molecule. So, unfortunately, biopsy needs to be performed for most of these. The one thing we can do in clinic is check for a tryptase level. So, it makes our job a lot more difficult, but we'll go through and decide who the most likely people are to have more significant, at least primary mast cell-mediated disease. So this is a subject I didn't cover a lot prior, and there wasn't a lot at the meeting either, but cutaneous mastocytosis in kids often regresses by puberty, and most of you know that, so bone marrow biopsy often is not necessary. And in one of the meetings, I forget who it was, one of the group in Spain said how they follow these people. Most of them, again, just do watchful waiting. They have them back every year or so and check for hepatosplenomegaly, any lymphadenopathy. They follow CBCs every year or two on these. And if their tryptase level is greater than 20, they usually trend it to make sure it's going in the right direction. But other than that, again, most of these kids do not need a bone marrow biopsy. Indolent systemic mastocytosis, again, very common. We probably have 12 or 13 patients that we see with this disorder, and it's very interesting. Some people have a ton of symptoms, a lot more in the way of daily mast cell-mediated release, and others are upset that I have to drag them back every year or two to check a CBC. And most of these patients should be co-managed with their hematology colleagues. But there's a normal life expectancy, and there's very, very rare leukemic transformation. Risks of progression are increased beta-2 microglobulin and c-KIT mutation in all cell lineages. And they do this at UW, but if you're getting a bone marrow biopsy at somewhere else, just make sure they're checking for that in all the lineages, because if other lineages have these mutations, they're much more likely to progress to the more severe types of mastocytosis. We also have one patient with smoldering systemic mastocytosis, which involves B findings, which is greater than 30% infiltration by mast cells in bone marrow, tryptase level of greater than 200, hepatomegaly, and signs of myeloproliferation. But even that guy has done fairly well, and we monitor him obviously a little more closely, but he's done very well. These other ones I've never seen, so I'm not going to spend a lot of time on. These are the ones that our hematology colleagues can help us out. Aggressive systemic mastocytosis is what we monitor for in these patients. So indolent systemic mastocytosis, again, I always check, or at least as much as I can, try to check for hepatomegaly, splenomegaly, look for cytopenia, so I'll get a CBC on these folks, and I'll usually at least try trending a tryptase every year or so. Mast cell leukemia, I've never seen a case. Unfortunately, it's easy to diagnose these because you can find the c-KIT mutation in the blood, because there's a lot of mast cells floating around, and there's not much we can do with these patients, and survival is less than a year. There's mast cell sarcoma, again, exceptionally rare, localized malignant mast cell tumor that causes destructive growth, and then extracutaneous mastocytoma, again rare, but it causes non-destructive growth. So, again, bottom line here is once these patients are diagnosed, screen periodically for cytopenias, end organ dysfunction, hypersplenism, and as I've touched on before, these patients need more periodic DEXs. What the right time frame of repeating those is, I don't know. It's different depending on who you listen to, but I at least try and repeat it every 3 to 5 years depending on the previous findings. So, there's mastocytosis. Again, this has been around for a long time, but this paper in Blood in 2007 is what kind of opened the doors for this monoclonal mast cell activation syndrome. The study was done at the NIH of 72 consecutive patients, referred to them for either idiopathic anaphylaxis, confirmed or probable mastocytosis. 24 of those patients had recurrent anaphylactic episodes, and 12 of them were subsequently diagnosed with mastocytosis. 12 of them did not meet mastocytosis criteria, and they further analyzed these 12 patients and found a few interesting findings. So there was evidence of morphologically, aberrant mast cells, elongated shapes, hypogranulation, so they just look different on the bone marrow biopsy. A lot of these patients had aberrant expression of CD25, which should not be on normal mast cells. All the patients over here, I didn't mention, had aberrant mast cell morphology. All of them had CD25. 3 out of 4, they didn't check it on the last one, but 3 out of the 4 had the D816V c-KIT mutation. So their findings were, in conclusion, an aberrant bone marrow mast cell population carrying clonal markers found in mastocytosis was detected in a high percentage of patients with recurrent anaphylaxis in this study. So that kind of opened the door for this monoclonal mast cell activation syndrome. And now they screen for all of this if you get a bone marrow. So they'll either tell you it meets criteria for mastocytosis versus monoclonal mast cell activation syndrome.
What distinguished them from just classic mastocytosis?
They don't have the nest of mast cells. They don't meet the classic criteria. And the big one is you don't see a lot of increase in mast cells in this disease as opposed to mastocytosis. You just see these abnormal markers instead, meaning they are somewhat mutated, and a lot of them have the D816V mutation. Why they don't progress to those nest of mast cells you see in bone marrow, we don't know at this point. But it's thought, and the simple way of thinking about it, it's not an increased number, but they're more twitchy and they're more prone to cause disease.
We have all the other features, they're just not clusters themselves.
Yes, and it's usually a more benign clinical course. So monoclonal mast cell activation syndrome, I just went over this. So affecting 2 or more organ systems, so you have to have the symptoms. Characteristic bone marrow findings. or they lack the characteristic bone marrow findings. Again, you don't have those nest of mast cells. And they need one or more of the minor criteria. The major ones are the c-KIT mutation and barren mast cells, and CD2 and CD25 are what they usually look for. So, all right. So, what if the patient doesn't meet criteria for a primary mast cell disorder? That leaves us down there in the idiopathic range, and we all struggle with this. We all have our idiopathic anaphylaxis patients, our idiopathic angioedema, idiopathic urticaria, and mast cell activation syndrome. So, in 2010, this started gaining momentum. First one was put up by Aiken again. A lot of this research is done in Boston and Spain. And then in 2011, all the mast cell gods, if you will, got together in Europe and came up with some criteria, because there's been a lot of people, especially depending on who's evaluating them, that are getting this diagnosis, and there are really no objective findings other than the history. So this tried to come up with a more objective way to diagnose these patients. So this original paper by Aiken basically said there needs to be 4 things to diagnose mast cell activation syndrome. Mast cell-mediated symptoms, which, as you know, can be very difficult to differentiate from a lot of other things. You need to have improvement with treatment, and the classic one here is histamine blockers, but you can use leukotriene blockers, mast cell stabilizers, other medications as well they accept. Increased mast cell activation marker, either a baseline or during an episode. And then, this is always simple, just rule out everything else. You know, it can be a very tricky diagnosis to make. So, evidence of increased urinary or serum marker. Again, I like tryptase. It's very reproducible if you check these serially. It's the one that's routinely recommended by all these panels and what they talk about at the meetings and such. So, in 2010, the working conference where all these guys, Valen, Aiken, Escribano, Metcalf, they all met in, I think it was Vienna, and came up with some criteria to try and unify the classification of mast cell activation syndrome. And I always tell patients this, you know, to meet mast cell activation syndrome, you have to have these, and it gives them a little more structure as far as when we're going through the workup. And they say this just, I think, because so many people are getting diagnosed and they wanted more objective criteria. Increased numbers of patients are now being informed that their clinical findings are due to mast cell activation that is neither associated with mastocytosis nor with any defined allergic or inflammatory reaction. This is to assist in the identification and diagnosis of patients with MCAS and avoid misdiagnosis. So again, you need these same criteria: signs and symptoms, improvement on treatment, and at least documentation of one of the elevated markers or elevation of a marker during an episode.
Hey, Drew?
Yeah.
Can you go back to the clinical criteria?
Yeah.
I guess what makes me uncomfortable is that, you know, any of the symptoms are common human symptoms. It could be gluten sensitivity, it could be, you know, you name it. And then the treatment could be a placebo. And then the lab abnormalities could be just a random event. And so, what are the most common symptoms these patients complain of versus a whole host of problems?
The difference is for clonal mast cell disease, the symptoms are fairly consistent. For mast cell activation syndrome, you know, we get the whole gamut. So, no, to answer your question, this is incredibly difficult, and I agree with every one of those statements.
Because this is sort of becoming the, I don't know, the fibromyalgia of allergy in a way, because it's...
I've referred to that.
Yeah, it's whatever you see it as, and I mean, I'm sure there's not any prospective data yet to sort of look at the treatments.
That's why I really like the tryptase level during these episodes. It's a very reliable marker. You know, if you follow these, they're usually within a point or two, and with the criteria they have as far as what's an elevation in the marker, I do this all the time, and I've only had 2 that have met that criteria.
Do we even know what normal tryptase levels vary throughout the course of a month or a day in normal people?
They don't, in my experience, they don't.
We don't check those in normal people.
In normal people, no, they are fairly reproducible.
But they had to check them in normal people, or we wouldn't have a criterion for what's elevated.
The other one, the urinary markers, they fluctuate. I very, very rarely use those other markers. They're much less reliable in my experience. So, no, it's a good question, and that's what makes this so tricky. is that people will get online, they'll read these criteria and say, oh, gosh, I meet these.
I'm
You know?
baked.
No, it's extremely tricky. So, they come down to they want 2 or more organ systems involved, and, they outvoted on what they thought mast cell symptoms were, and flushing, pruritus, urticaria in the skin, nasal congestion, pruritus, wheezing. So again, the whole gamut of symptoms. So that's, again, what makes this very difficult. Now, in this paper, they really only advocated for tryptase level because they are reproducible, and they said in published and presented data at the conference, the members agreed, or 80% of them, that the total tryptase level should be at least 20% plus 2 the baseline during one of these episodes. So I always go through that with them, and if they don't meet that, say, you don't meet mast cell activation syndrome at this point. And for the most part, these patients are receptive to that, and that's why I always bring out this scoring system, the REMA scoring system with them, and go through it. What differentiates primary, secondary, and tertiary, or an idiopathic. And for the most part, no matter how much they've investigated on the internet, they seem to be okay with that classification.
What's the time frame for obtaining the tryptase?
Ideally within 90 minutes up to 3 hours. And you always take into account when it was drawn. They peak at about 15 to a half hour and then kind of slowly go down. I had a patient that got it done exactly a half hour after she passed out. The tryptase was exact same during these episodes. She has a lot of other reasons to have that. So she was very receptive to the fact that I don't think this is mast cell activation syndrome. I don't think mast cells are playing a role.
Does it require special handling after it's obtained?
Most people know. I send them to our labs, and I always give them a lab slip to have my fax, have it faxed to us. And for the most part, they get to us and they're fairly reasonable. But if possible, I like to have it done in the same lab where it's been done before.
It doesn't have to be kept cold or anything.
No, it's not too much of a finicky assay, and I rarely have them call back and say we didn't get a good sample. So again, the 4th criteria always rule out everything else, and I'm not going to go through all these, but as you know, the workup with these are difficult as well. So this table, systemic mastocytosis, monoclonal mast cell activation syndrome, and idiopathic anaphylaxis. So the baseline tryptase is usually significantly elevated. Systemic mastocytosis, MMAS and MCAS can be normal or mildly increased, and idiopathic anaphylaxis, it's usually normal at baseline. Again, the clonal disorders usually have a c-KIT mutation and or CD25 abnormality. And Len, back to your question, the way to differentiate is looking for these mast cell aggregates on bone marrow. So, and sending it to the U, most of the docs there are pretty darn savvy about looking for all of these individuals. Again, back to my classification. So primary, again, you have to do a bone marrow biopsy. Secondary, normal quality and function of the mast cells that usually respond to external stimuli. Again, I don't need to go over a lot of this with this group. Allergic disease, i.e. IgE mediated. Physical urticaria, as we all know how to diagnose. Autoimmune urticaria, again. And then neoplastic and hematologic conditions such as solid tumor, breast cancer, Hodgkin's lymphoma, aplastic anemia can all present with this as well. And then the idiopathic. It may be in the future that these idiopathic disorders may be shown to be a primary disease, more like these monoclonal mast cell activation syndrome patients, or there may be a secondary driving factor. But I explain to these patients we just don't know why. Especially if they do meet criteria for the mast cell activation syndrome. Again, it's really easy. It's just everyone that walks in the door, you should get a bone marrow biopsy on them. Obviously, it's not that simple. So, this is another paper. If you have any chance, this is the one. If there's one paper I'd read on this, it'd be this one. It was several years ago, I think 2011 is when it came out, looked at the clinical, biologic, and molecular characteristics of adult patients with systemic symptoms suggesting mast cell disorder and the absence of skin lesions. So there are 83 patients identified, and as you can see, pretty typical. They had a wide range of symptoms that they came in with. Bone marrow biopsy was performed on all of these patients, and clonality was defined as what we talked about before, c-KIT mutation, looking for mastocytosis, CD25 expression. Clonal mast cell disorders, another frustrating thing about going through this literature is they have a lot of different names for the same condition. So indolent systemic mastocytosis with a little s and a negative, that's without skin symptoms. Indolent systemic mastocytosis with skin symptoms are urticaria pigmentosa. And then clonal mast cell disease is both of those, or monoclonal mast cell activation syndrome and mastocytosis patients. So non-clonal mast cell activation disease is the same thing as mast cell activation syndrome. So, in going through this literature, there were 83 patients that were screened with mast cell symptoms and a slightly elevated tryptase, although they didn't say what their tryptase cutoff, because one of them had a tryptase of 3 in the study. They had a biopsy performed, and amazingly, 51 of these patients either had systemic mastocytosis or monoclonal mast cell activation syndrome. And then 32 of them had a normal. Actually, this is a mistake. This should be mast cell activation syndrome patients. So 32 of them had no evidence of clonality. So what differentiates these patients? So non-clonal mast cell, so that's mast cell activation syndrome. Indolent systemic mastocytosis, that's the mastocytosis in a study that was diagnosed by bone marrow biopsy. And this was their control group. Indolent systemic mastocytosis with urticaria pigmentosa. So as you know, or as you can see, a lot more of the true clonal disease, indolent systemic mastocytosis, were male, 73% versus the non-clonal, only 31% were male in that group. So the age at onset, they seem to be similar, although, and there's a reason for this, I think, mostly because these patients present with urticaria pigmentosa, which is much easier to pick out. A dermatologist is usually the one that figures that part out. The tryptase level was significantly lower in this group of the non-clonal mast cell or mast cell activation syndrome compared with indolent systemic mastocytosis without skin symptoms. And then, again, there seem to be more males in this indolent systemic mastocytosis group without skin symptoms compared to the ones with skin symptoms. And they were this is fairly intuitive, the ones with their skin lesions are more likely to have pruritus. So, again, this is one of the tables I refer to all the time. So there were a higher percentage of patients that reacted to insects in the indolent systemic mastocytosis without skin symptoms. The mast cell activation syndrome patients were much more likely to react to a drug, amoxicillin being the most common. And interestingly, neither of these groups had higher rates of reactions to foods, so who knows what that means. Also interesting in this paper was that specific IgE was found in 35 of the 41 patients that had Hymenopterous thing that triggered one of the episodes. In all 6 of these patients, clonal mast cell disease was identified. So if there's a good history for anaphylaxis, negative IgE testing, I would definitely look into mastocytosis or clonal mast cell disorders in these patients. Again, here there's kind of 2 phenotypes here. The non-clonal disease, mast cell activation syndrome, seem to have more urticaria, angioedema, and dyspnea, whereas the clonal disease seem to have more in the way of syncope and hypotension, so that's usually a red flag. And again, they went through this even more, saying for clonal disease, they're usually male, usually have absence of urticaria and angioedema. Dizziness and syncope is a major symptom for them. Insect being a trigger is also a major symptom, and a tryptase level greater than 25. It was for non-clonal disease, again, female, presence of urticaria and angioedema. Respiratory symptoms, drugs as a trigger, and tryptase less than 25. So this is a table I refer to on a weekly basis, and I try and calculate these on each patient that comes in with a question of mast cell activation syndrome. So you get a point for being male, you get minus a point for being female. Urticaria and angioedema actually drop you as points, and syncope is a major score here with positive 3. And the higher the tryptase, not surprisingly, the more points you get. So we'll go through a few of our initial patients here.
3 points to win.
2. You get 2. Equal to or greater than 2, you get the jackpot there. And this may be dumb luck, but I've sent, I think, 5 or 6 patients for this, and everyone scoring above 2 has had clonal disease. Everyone below it has not. So it's worked very well for me. So I'm not going to go through cutaneous. Here's the way I go about this, and it's changed over the next few slides. But if they have cutaneous lesions, obviously get a skin biopsy. If they're positive, get a tryptase. Lisa and I saw a patient last week who had been diagnosed with urticaria pigmentosa. She's in her 40s, I believe. It was 10 years ago, and no one ever got a bone marrow, so that needs to be done in adult patients, but not kids. So if there's no cutaneous lesions, I usually get a lab workup, tryptase, CBC with differential. If the tryptase is greater than 20, send them for biopsy. If it's less than 20, I use the RIMA scoring system. RIMA is just the name of the facility that they do a lot of this work in Spain. And if it's less than 2, I'll consider mast cell activation syndrome. Here's another nice paper on the definition, criteria, and global classification of mast cell activation disorders. Again, just differentiating primary from idiopathic, secondary, allergic, autoimmune, neoplastic. Most of us are pretty good at this. And to say that they're not mutually exclusive. So mast cell activation or clonal mast cell disease can have IgE-mediated phenomenon, so they can go in and out of these different categories. So here's my algorithm based on all of these papers. Try and get through the next few as quick as I can. So if they have symptoms consistent with mast cell disease, if there's a tryptase greater than 20 on 2 occasions, I send them to our oncology colleagues, and they almost always get a marrow. If the tryptase is less than 20, I usually go through the RIMA scoring system, and if it's greater than 2, I would consider a bone marrow biopsy. I'll usually talk with the patient pros and cons, but again, everyone I've sent, they're nice enough to do a bone marrow for us. If the score is less than 2, I usually give them a lab slip. I get a baseline tryptase, have them get a tryptase during one of these episodes, and most of them have done that for me. So the tryptase is greater than 1.2 plus 2 the baseline, then meets this criteria, especially if they responded to antihistamines and some of these other ones. And mast cell activation syndrome, you know what to do with these patients once you find them. You treat them with anti-mast cell treatments. The main one is antihistamines, but you can try a lot of different things. And they do meet that criteria. What that means at this point, there's a lot of research going into, if there's underlying primary disorders versus secondary disorders in these patients. This is new from last year. I saw this. It was Aiken's review and up to date. I'm happy to say his algorithm is almost the exact same as mine. So they are the experts in this, recommend a similar workup on these people. So how and who to screen. Obviously the history, and most of us know how to screen for that. On all these patients, I do a fairly thorough skin exam, check out their legs, abdomen, torso. Look for anything consistent with urticaria pigmentosa, look for Derriere sign if there's something is consistent. Try and do an abdominal exam, looking for hepatosplenomegaly. I'll get a tryptase. I order this maybe once or twice a year. There's some other urinary tests, blood tests, and histamine in plasma. It has a very short half-life, so it's a very finicky test to get done. So I'll only do this if I have a very high suspicion for mast cell-mediated disease. In 24-hour urine, you can do N-methylhistamine. We saw a patient a couple weeks ago I'd been seen at the Mayo Clinic. Evidently, they do a lot of that there. Urinary prostaglandins, but again, they're not as sensitive and specific. So I'll only do that if I have a very high suspicion. So back to our first case. He had an episode of anaphylaxis after Bolt House, chai tea, called 911, was hypertensive, had a tryptase level of 39. So going through his scoring system, 1 point for being male, 1 point for no urticaria or angioedema. Pre-syncope gave him 3, and a tryptase level gave him 2 points. So he's well above that 2-point cutoff. So this patient deserves a biopsy, and he had mastocytosis. The next case, 42-year-old female, which is a lot of what walks into our clinic. Several episodes of hives, angioedema, lightheadedness, can't concentrate, had a baseline tryptase of 5 and a tryptase level during an episode that was 9. Started on cetirizine and did better. Who knows? We can't do placebo, trials with these folks at this point. So she meets criteria for mast cell activation syndrome. And again, I've had 2 in the last couple of years that have met this and follow them clinically. I may get a DEXA depending on their age and things like that. But it's for whatever reason, patients really like getting this diagnosis.
What's her score?
I didn't run her through there because I don't think she would deserve a biopsy. She meets mast cell activation syndrome. Her score would have been less than 2.
I think you have it on the next slide.
So she's female, -1, did not have significant hypotension, although you could classify that lightheadedness. She had urticaria and angioedema, so no, she would not be. She would be below. Oh, and here it is. She's a 0. So she.
We did do it.
Yeah. All right, I'm going to have to race through these last few.
All these syndromes you're going to treat the same anyway. You're going to treat the symptoms. Does it really make a big difference that you go?
Well, all the mast cell activation, the primary disease you treat very differently. So there is a risk for malignant transformation, so you need to follow it. They have a much higher rate of osteoporosis.
So you got to follow them.
You have to follow them much closer if it's primary. The mast cell activation syndrome, that's a different story, and that's still being teased out.
What do you?
Because you're going to treat them all the same anyway, whether.
The other nice thing is that what you treat them with, like Singular and Zyrtec, it's very benign. So
the monoclonals also clearly need epi with them at all times. Do you give it activation?
I give everyone with clonal disease and epinephrine. People with mast cell activation syndrome, if they have a history of anaphylaxis, I'll usually give it to them as well. So this is a case by Bonadonna, who did a bunch of talks at the meeting this year. And this is her most famous work, where they screen. They must see all the insect anaphylaxis in the country of Italy there, where they screened 379 patients with systemic reactions to Hymenoptera with a tryptase level. 42 or 11.6 had tryptase greater than 11.4, which is lower than previous cutoffs of 20. And they were able to convince 34 to go to bone marrow biopsy. 21 of these patients were diagnosed with indolent systemic mastocytosis, and 9 of them had monoclonal mast cell activation syndrome. So 30 of the 34 had clonal disease if they had a systemic reaction to Hymenoptera and a tryptase level greater than 11.4. 4 of the 379 had a negative workup by serum IgE, by a skin test, and intradermal test, and all of them were diagnosed with a clonal disease. So in patients that have a systemic reaction, that's a convincing story that our IgE testing is negative. I think they all need to be screened for mast cell or primary mast cell disease. So going through this in patients with normal baseline serum tryptase versus those with elevated, the differences is there's a slightly increased age, so these patients were closer to 50 than closer to 40. They had an elevated tryptase level. The patients with negative IgE testing were much more likely to have an elevated tryptase level in this study. And the patients with severe anaphylaxis, they were more likely to have an elevated tryptase as well. So in patients where you don't find evidence of IgE, for these patients with a convincing history, obviously, or with severe anaphylaxis, I would recommend getting a tryptase in these folks. Kind of went through all of this. So this is the first study where they used the cutoff of 11.4. Previous studies had used 20, and they would have missed a lot of the patients had they used the cutoff of 20. So more research needs to be done into this. So again, consider bone marrow biopsy if anaphylaxis and tryptase greater than 11.4, anaphylaxis without IgE, and a history of severe reaction.
Is that now the standard cutoff for tryptase internationally, 11.4?
Depends on who. That's our assays. All the assays I've seen use that cutoff. As far as mastocytosis, it's still 20. But as far as an abnormal level, 11.4 is every assay that I've seen.
That's an absolute value and not a rise during symptoms.
That's an absolute value. Yeah. They just check this at baseline in all these patients coming in for this study. Previous studies did not show a higher rate, but there is a reason for that. this first study that only found 1% of patients only looked for cutaneous mastocytosis, which does not seem to be this phenotype. Couldn't find data on that study. Didn't do bone marrow biopsies in all patients. In this study, I found a 2.6. This study, which found the second highest rate, used a higher tryptase cutoff, and I believe it was 20 in that study, so they would have missed a lot of the patients as was shown in this study. And I couldn't find data on this, but bottom line is, this is the only study that has done bone marrow biopsies in all patients with systemic reaction and a tryptase level greater than 11.4, so it's at least worth thinking about when you see these patients in clinic. Another thing I'm going to quickly go through is another reason to get a tryptase level is patients with increased tryptase levels here, odds ratio here, and the baseline tryptase. So the odds ratio is around 1 if their tryptase is 5, but if it gets up near 20, they're 10 times more likely basically to have, or significantly more likely to have anaphylaxis during immunotherapy. So baseline serum tryptase is a risk factor. Therapy with honeybees is a risk factor, which most of us know. And then ultra-rush therapy, and not surprisingly, are other risk factors for having a severe systemic reaction during administration of immunotherapy. And this is a study that just came out recently, and this was a kind of a theme at the meeting, saying there seems to be this individual phenotype that's mainly males that just have anaphylaxis to Hymenoptera, and it seemed to have a lower tryptase level. So there were 3 groups in this study, a total of 271 folks. 143 of them just had, they have a huge cohort, 143 of them just had anaphylaxis with insects and were diagnosed with indolent systemic mastocytosis. Other indolent systemic mastocytosis, you can react to insects, but you also react to a lot of other external triggers. And then they have their positive control, which is indolent systemic mastocytosis with skin symptoms, urticaria pigmentosa. So compared with these other 2 groups, the insect-only group had a much higher male predominance, had lower tryptase levels. 22.4 was the average, versus those that reacted to other triggers. The average was 28.7, and the patients with urticaria pigmentosa and the classic mastocytosis had a much higher baseline tryptase level. They were less likely to have these bone marrow aggregates, and they had a mast cell restricted KIT mutation, meaning they didn't have it in other cell lines, and that also speaks to the fact that they're much less likely to progress to a more malignant form of this disease. They were also a lot less likely to have symptoms in between these episodes. If you see these patients, they don't complain of much in between. They're just very afraid of being stung by these insects. So they don't have the itching, pruritus, or GI symptoms that go along with other folks with indolent systemic mastocytosis with skin symptoms. All right, and I'm going to breeze through this. I could not find this article. For whatever reason, UW doesn't have International Archives of Allergy and Immunology, and actually they've had a lot of good articles that have come out recently, so I'm petitioning to get this on at UW, so I couldn't get a hold of this, but it looked into the validation of the REMA score. And in both patients with mast cell activation syndrome exclusively triggered by insects, as well as total mast cell activation syndrome, the sensitivity is much higher than a baseline tryptase. The specificity is about the same. So running them through the REMA score seems to be more sensitive, and this other study speaks to the same thing. Using the REMA score, it's much more sensitive as far as picking up who's going to have clonal mast cell disease, both for clonality and for systemic mastocytosis. So back to case 3, again, had a nice systemic reaction. Assuming I believe the history, does this make mastocytosis more or less likely? So given the fact that he had a severe reaction, I think I would check a tryptase level on him. And he also had no serum IgE or skin prick or intradermal IgE, which again makes the likelihood of a mast cell or primary mast cell mediated disease much more likely as well. So here's my total algorithm here. So Symptoms consistent with mast cell disease, which, as we discussed, is difficult, but I look for a tryptase level. If it's over 20 on 2 occasions, I send these patients for bone marrow biopsy. If it's less than 20, I'll run it through the REMA score. Scores greater than 2, I will talk with the patient, list pros and cons, and for the most part, most of them seem to want a bone marrow biopsy. And I think if the score is greater than 2 on this scale, that's very reasonable. So if they don't meet that, their score is less than 2, I give them a lab slip, have them get a tryptase level in the setting of an event, and put them through that criteria. So if they meet mast cell activation syndrome, I go through different causes, and the million-dollar question is, what else do you do with this other than just treat these patients? Same with Hymenoptera anaphylaxis. If it's a severe episode, at least I will get a tryptase level. If it's greater than 11.4, I will seriously look into mast cell-mediated disease. Looks like I have a minute. So why screen for these disorders? And this is a question that comes up. One, it's giving the patient a diagnosis. You also need to screen for signs of mast cell infiltration. Again, I'll usually get a CBC, looking for infiltration into bone marrow, and then get a metabolic panel looking for liver dysfunction or any other dysfunction where mast cells could be playing a role. Get regular DEXA scans. Again, I'm not sure. I usually get it at a baseline when they're diagnosed, and I don't know what the optimum screening, but every 3 to 5 years is what I've been planning on. Let's see. Patients with mastocytosis have more severe reactions. And that's another point here. If you do have patients with Hymenoptera anaphylaxis, and they are positive to IgE testing, the recommendations are to have them on lifelong prophylaxis. A lot of mastocytosis patients that went through the typical 3 to 5 years, there's been 4 or 5 deaths reported after them going off immunotherapy. So if you do diagnose clonal mast cell mediated disease and insect anaphylaxis and put them on IT, they need to be as close to lifelong as possible.
What about the group that's IgE test negative? Anybody recommend Venom immunotherapy?
Depends on who you talk to. No is from what I gather, no. But I've seen people that do it anyway, even if they are negative.
Yeah, you don't know what Venom is. Freedom with it.
I know. And when they do it, they recommend all of them. So I wouldn't, but I've heard people that say they would.
Do you have any data on after you desensitize these people to venom? Do any of these variables change? Does their tryptase level go down? Do their mast cells
I don't know if the tryptase
disappear?
level. You wouldn't think the tryptase level would go down at all, so I don't know that. But
Unless there's some magic.
we do know they do better on IT. So yeah, I mean, the outcomes are much better when they are immunotherapy. So if you do diagnose as close to lifelong as possible, but I don't know about whether their tryptase level is good. I'd be surprised if they did. And hopefully new therapies are on the way, and they briefly outlined these at some of the meetings as well. So, if you guys are at all interested, I know you all have a bunch of free time, so these are the 3 papers I would recommend reading. Most of them are fairly quick reads, and they're what I refer to over and over as far as how to manage these folks.
How about the guy with the chai tea reaction? What does that have to do with anything? It was just coincidental?
Yeah.
You said you've seen it.
I have too.
And that's what I wonder.
I've heard these tricky with that pen in hand.
Energy.
This one has a ton of soy.
I don't know whether that plays a role.
I don't know what the word chai means. What the hell is that?
That was teeth.
Tea is tea.
I thought just teeth. That's right.
It says it means tea.
You got Matt, what's it?
Has anybody, most of these patients do well with just antihistamine and conventional therapy. I've never seen it, but clearly some of the true systemic clonal disorders don't, and then a lot of the mast cell activation do not. You'd think that Gleevec might work, even though the mutation's downstream, just because you're blocking some of the differentiation you may need to treat for a long time. Or David was asking about maybe a JAK inhibitor. Has anybody tried either on a case report level or in a series or something, either of those for sustained periods of time?
There are case reports, and I admit I haven't read them, but there's a group down south, and I can give you their names, who have...
Think they're useful potentially?
They think they're useful. There's no data as far as I know, but they use a lot of different agents to treat this. and I'll show you. There's a paper.
Yeah, I mean, it might make sense, especially, it may take a while because mast cells have such a long tissue half-life.
And that's their argument, but, you know, this is without getting too far.
Yeah, they're expensive, but.
Any data on people with really big, large local reactions in this, with tryptase is elevated? Now that there's recommendations to treat them with immunotherapy, I mean, does any of that get crossed over to large local reactions?
The only literature is just yeah, that's a good question.
What about patients with idiopathic anaphylaxis? Do you think that all of them should have
Especially the people who are negative on testing.
all the patients with idiopathic anaphylaxis are vulnerable in that?
That's what they did in the study.
It makes sense that everyone with idiopathic anaphylaxis.
And a lot of studies haven't been done other than that one. But you know, as far as who's likely to have these plug a lot of these patients into their immune disorder.
I want to know more for the big ones. Yeah.
But most of the patients are so desperate and
Does anybody?
it'd be interesting because that's the only study that
I need a letter for take my board.
Gone anywhere yet?
Okay. And that was a very small study.
I just saw
I've got motor loss in my
he had his first brachial angioedema attack at almost, and then 1 year, it's like at 8 o'clock at night, just swelled.
And then if I fail,
Start getting sugar bread, coffee, yeah, gear, veggie, no, I just repeated last second tip days. Chuck's getting